Good morning. Thank you so much for being here. Nancy, I will pass it over to you. The floor is yours.
Thank you, Jane. Thank you, everyone. Thank you very much for joining us for today's HRSA Office of Women's Health Leadership Series on domestic and international cervical cancer response in safety net settings of care. I'm Nancy Mautoni-Smith, the Director of the Office of Women's Health, and I want to welcome you to the first webinar in our 2022 Women's Health Leadership Series. Today's event is a collaboration between the Office of Women's Health, HRSA's Office of Global Health, and the NIH National Cancer Institute. The United States Congress designated January as Cervical Cancer Awareness Month. While there's been significant progress and many advances in prevention and treatment over the past 40 years, cervical cancer remains the fourth most common cancer among women in the United States. We also know that cervical cancer screenings declined nationally throughout the COVID-19 pandemic, underscoring the importance of prioritizing cervical health now more than ever. I'm pleased for today's event, which will include perspectives from federal efforts within domestic and global health programs. This type of collaboration embodies the spirit of our Women's Health Leadership Series. Throughout 2022, we will aim to continue to bring you collaborative content designed to advance public health approaches to improve women's health outcomes. Now I'd like to turn it over to Ms. Jane Segebrecht, who leads OWH's Federal Cervical Cancer Collaborative. Thank you, and over to you, Jane.
Wonderful. Thank you so much, Nancy. We are really looking forward to today's event, and greetings, everyone. Today, you will hear from the HRSA Office of Women's Health about our partnership to support cervical cancer control and prevention in safety net settings of care. Then, the National Institutes of Health, National Cancer Institute Healthcare Delivery Research Program will share updates on their landscape analysis research. And then we'll move to perspectives on global cervical cancer prevention from the HRSA Office of Global Health and JPIGO, including a review of the growing global inequities of cervical cancer, WHO acceleration plans for elimination, the PEPFAR Go Further partnerships, and JPIGO's cervical cancer prevention experience in Namibia. And lastly, the Office of Global Health will offer reflections, and then we'll open for questions. So please use the chat box to raise questions throughout today's presentation. And today's event is being recorded and will be made available on our website. So first, a bit about our agency. And as you get to know us, please help us to get to know you too. You can add to the chat your name, your organization, and where you are joining us from, as I know we have an international audience for today's event. So HRSA is an operating division within the U.S. Department of Health and Human Services, and we support more than 90 programs to provide healthcare to people who are geographically isolated, economically or medically challenged. And our programs serve tens of millions of people, including people with HIV/AIDS, pregnant women, mothers and their families, and those otherwise unable to access quality healthcare. So HRSA Office of Women's Health provides leadership on women's health and sex and gender specific issues and works to improve the health, wellness, and safety of women across the lifespan. And we do this by providing subject matter expertise and technical expertise to HRSA's administrator on health issues impacting women. We lead cross-agency collaborations to address key issues of concern for women, and we lead consultations to inform HRSA investments in women's health. So cervical cancer is a sentinel malignancy of health disparities. Women with routine access to accurate screening, which can identify and remove precancerous lesions, rarely develop the cancer and even less frequently die from it. And women with fewer resources and limited healthcare access are less frequently vaccinated, screened, and treated, particularly at the precancerous stage. And we know that cervical cancer does not discriminate. So cervical health warrants sensitive and inclusive prevention, screening, and treatment for all patients at risk for cervical cancer. So cervical carcinogenesis follows a universal flow from infection with human papillomavirus or HPV, persistence, and then progression to precancer and then cervical cancer. And in addition to cervical cancer, HPV is a risk factor for 5 additional cancers. And public health prevention through HPV vaccination is one of the best tools in our arsenal to prevent several cancer-causing types of HPV, especially HPV type 16. However, control efforts based on vaccination, solely vaccination alone of adolescents are estimated to take another 40 plus years. So screening and management advances are of critical import to public health and women's health. So in response, HRSA Office of Women's Health is working on efforts to advance clinical management guidelines, such as the risk-based guidelines released by ASCCP. In response to this identified public health need, HERSA and our HHS partners listed here, NCI, the NIH Office of Research on Women's Health, HHS OASH, Office of Population Affairs, and CDC Division of Cancer Prevention and Control are co-sponsoring the Federal Cervical Cancer Collaborative. And you may be familiar with the Accelerate Cervical Cancer Control Project as part of the NIH NCI Cancer Moonshot. This aims to accelerate research to make more therapies available to more patients while also improving the ability to prevent cancer and detect it at an early stage. And our collaborative bridges the federal priorities of cancer research at the NCI with healthcare delivery and what we're doing in HERSA-supported safety net settings of care to implement and realize the outcomes of the Cancer Moonshot in safety net settings. And the collaborative is our first activity together as a group is hosting a roundtable series. And this will focus on bi-directional sharing of provider experiences, guidelines, technical assistance needs, and opportunities to advance evidence-based interventions such as self-collection for HPV in safety net settings of care. And we will host 3 roundtables this year. We are starting first with an event on opportunities in territories, including Guam and the US affiliated Pacific Islands, then Puerto Rico, and then the US Virgin Islands. And then next we will have a roundtable to engage perspectives from the stakeholder community. And third, a roundtable to strengthen federal coordination. And this series will inform a provider toolkit so that providers and safety net settings of care are poised to realize the outcomes of the Cancer Moonshot and bring the most current and actionable approaches for cervical health to the communities that they serve. So it is now my pleasure to introduce Veronica Sholette from the National Institutes of Health National Cancer Institute. Ms. Sholette is a program director in the Health Systems and Interventions Research Branch of the Healthcare Delivery Research Program. And she has been managing grants at NCI for over 30 years. In HSIRB, she manages NCI-funded social and behavioral research directed at multiple contextual levels to improve rates of cervical cancer screening and HPV vaccination, factors associated with disparities in prostate cancer, PSA screening, and the downstream consequences following screening, and studies to improve interprofessional teamwork in healthcare delivery. Ms. Sholette is a co-lead of the Healthcare Teams Initiative, which addresses strategies to improve patient outcomes through the delivery of healthcare grounded in principles of evidence-based team research. So Veronica, I will now pass it on to you. Thank you so much.
Thank you so much, Jane, for that introduction, and thank you to the Planning Committee for giving me the opportunity to share one of the activities the NCI's Healthcare Delivery Research Program is doing in the research space as a partner of the Federal Cervical Cancer Collaborative that Jane so eloquently described in her remarks. Next slide. Next slide. Thank you. So a high priority of the federal partnership was to ensure that our efforts reflected an in-depth understanding of current research approaches to prevention, screening, and treatment of abnormal cervical cancer screening tests and cancer precursors, particularly as it relates to safety net settings of care. And to accomplish that shared interest, one of our early activities was to conduct a cervical landscape analysis. And we wanted the landscape analysis to help us understand the current facilitators and barriers to effective cervical cancer screening. We wanted the analysis to help us inform the content of the roundtable meeting agendas and the content of the toolkit for providers of safety net settings of care, mentioned by Jane in her remarks as one of the products of the Federal Cervical Cancer Collaborative. And we hope that what we learned from the landscape analysis significantly will strengthen our ability to accelerate cervical cancer control and prevention in safety net settings of care. Next slide. So several questions. Next slide. So several questions guided the landscape analysis. And for the sake of time, this slide shows our 3 overarching questions. What are the current range of approaches used to manage abnormal cervical cancer screening tests and other evidence of cancer precursors? What is the readiness of HRSA-supported settings and other safety net settings of care to successfully implement recent cervical cancer screening guidelines? And what are the multi-level factors and barriers to adopting new screening guidelines in safety net settings of care? Slide 5, please. So going beyond the traditional approach of a current literature review, our efforts went a step further. The landscape analysis included a review of current HHS funding and cervical cancer research on screening interventions in low resource settings, outcome reviews of CDC's breast and cervical cancer programs, and we also reviewed resources to support evidence-based screening strategies. And our one-on-one conversations with HHS and NCI staff and grantees that conduct cancer screening research filled knowledge gaps of current approaches to enhance the effectiveness of screening medically underserved populations. Our data sources included the NCI grants portfolio and our evidence-based cancer control program cervical cancer screening database. Other data sources included the Community Services Preventive Services Task Force Community Guide, the PCORI reports on cervical cancer screening behavioral intervention studies in real resource settings, as well as the CDC National Breast and Cervical Cancer Early Detection Program summaries. Next slide, please. So for the short term, we have completed the landscape analysis. It is currently under review by NCI and will be shared with the Federal Cervical Cancer Collaborative team and posted on the NCI and HERSA websites this month. We also plan to publish a commentary on our approach, methods, and findings. In the future, we hope to consider the findings of the landscape analysis in the context of other cancer screening behaviors, such as breast and colorectal cancer. We also plan to stimulate research on the interplay of adopting new screening guidelines and the implementation of practices that are outdated or that provide low value or that are simply ineffective. So thank you again for the opportunity to share our approach to understanding the landscape of cervical cancer screening in low resource settings. Next, Dr. Ade Tisoye, Director of HRSA's Office of Global Health, will provide a brief overview of the Office of Global Health and how it works as an implementing agency of the President's Emergency Plan for AIDS Relief, which supports investments and partnerships to support the eradication of cervical cancer among people living with HIV. Dr. Ade Tisoye, over to you now.
Thank you so much, Ms. Sholette. Really appreciate those remarks that you have provided about the great work that NCI is doing. Sorry here. Okay, so greetings, everyone. I am Dr. Ade Tisoye with HRSA's Office of Global Health. It is our great pleasure to partner with HRSA's Office of Women's Health, NIH, NCI, and HRSA's funded global implementing partners to highlight cervical cancer elimination strategies and really understand recent innovations in cervical health. Diverse partners working together to achieve HIV/AIDS epidemic control and improve the future of women is a cornerstone of the President's Emergency Plan for AIDS Relief, otherwise known as PEPFAR. HRSA is one of PEPFAR's longest and proudest implementing agencies, and we're excited to discuss the important and worldwide public health problem of cervical cancer with you today, alongside our funded partner, JPIGO. Next slide, please. The Office of Global Health exists as one of the offices in the Office of Special Health Initiatives at HRSA. Our vision is to improve the health of Americans through global action. And our mission and goals align with this vision through supporting HRSA's contributions to US diplomacy and global health priorities, elevating US representation, policy, and technical engagement with multilateral organizations, contributing HRSA program expertise in strategic dialogue with other countries, advancing health and mitigating disease threats in the US-Mexico border region, advancing women's health domestically and abroad with a focus on addressing maternal mortality and cervical cancer, enhancing global dialogue and telehealth to improve and expand access to care, and leveraging HRSA's successes domestically to improve health outcomes globally. I'll now hand over to Commander Alpa Patel-Larsen, who will give some brief remarks about the PEPFAR program. Alpa, over to you.
My apologies, my other mic was not. I think you can hear me twice. Oh.
We can hear you.
Okay, and I was hearing myself twice because I'm logged in twice. My apologies. So yes, greetings to everyone. Thank you, Aday. My name is Commander Alpa Patel-Larsen, and I'm the Director of the Division of Global Programs here in the Office of Global Health. So the PEPFAR program does develop the strategies, priorities, and guidance to frame the program implementation, and they're shared annually through its country and regional operations plans called COP-ROP. These include how the countries will continue to enhance and sustain services for the benefit of the for HIV epidemic control, especially for priority populations, such as adolescent girls and young women. And cervical cancer is the #1 cause of cancer mortality for women in African countries served by PEPFAR. And HIV infection magnifies that risk 6-fold. So ending HIV, ending AIDS and cervical cancer is a prominent part of the current 2022 guidance for PEPFAR implementation. And we anticipate this continuing for improving services among women and educating men about the importance of screening and being supportive for their female partners. So COP-ROP annual process requires that cervical cancer screening is conducted in the 12 countries participating in the Go Further partnership. And that's selected based on high HIV prevalence among women in the 15 to 49-year-old age group, and all using COP-ROP funding. And all countries using these PEPFAR resources for cervical cancer prevention services are expected to adhere to that 2022 specific guidance and report on the indicators developed. Next slide. So the Go Further campaign is a public-private partnership which aims to reduce new cervical cancer cases by 95% among the estimated 7.1 million women who are living with HIV. And these exist in the 12 African countries, which have some of the highest HIV prevalence and cervical cancer incidence in the world. And partners seek to continue their support in these countries to integrate and scale up cervical cancer screening and treatment services for all women living with HIV from that 15 to 49 age group mentioned. And that is with the national guidelines as well in those countries in an effort to support mothers, sisters, and daughters who bravely confront HIV and cervical cancer diagnoses every day. And those 12 countries, African countries highlighted on that slide is Botswana, Eswatini, Ethiopia, Kenya, Lesotho, Malawi, Mozambique, Namibia, Tanzania, Uganda, Zambia, and Zimbabwe. And HERSA OGH PEPFAR also, next slide, my apologies. HERSA OGH PEPFAR also remains steadfast in its commitment to partner and support on-the-ground mobilization of cervical cancer elimination. So now we'd like to introduce our two esteemed speakers. First, Dr. Veronica Reyes is a technical advisor with HW21 Japaiga, Namibia, who's an MD OBGYN with more than 25 years of experience in health and women's cancer. Our second speaker is Dr. Cornelia Mfun, a medical practitioner and public health expert who also joins us from HW21 Japaiga in Namibia with more than 19 years of experience in public health program implementation in HIV care and treatment, prevention of mother-to-child transmission, tuberculosis prevention, and now cervical cancer prevention. So our presenters are going to discuss cervical cancer among women living with HIV, recent World Health Organization updates and facilitators and barriers to program models that may support scaling up cervical cancer prevention and closing those treatment gaps. And of course, that further knowledge building, the bidirectional learning that we're excited to be presenting today. Thank you.
Hi, good morning, good afternoon, everyone. It's my pleasure today to present the GPIG effort in support to the global effort to advance cervical cancer prevention. Thank you very much for this opportunity. Next slide, please. So I'd like to start to highlight the growing inequity around cervical cancer. We know that it's a completely preventable disease, but still we have so many women die from this disease. And most of the new cases of the cervical cancer and also the death occur in low and middle-income countries where we know that the access to vaccination, screen, and treatment is limited. And we also know that if we continue doing what we have been doing so far, we expect to have this scenario worsen by 2030. And we know that women living with HIV are in a more challenging condition because they are 6 times more likely to develop cervical cancer than women in the general population. Next, please. So we know what we need to do to prevent and even eliminate cervical cancer. So this graph from WHO from 2013 showed us what are the main interventions to prevent cervical cancer in the life course of women. So we should invest in primary prevention, mainly in HPV vaccination, secondary prevention with screen and treatment of precancer lesion. And if we fail in the first and the secondary prevention, we should go to the tertiary prevention and invest in cancer diagnosis, treatment, and palliative care. Next, please. The situation is that the access of this intervention is very limited in low and middle-income countries. But the good news is that we have a renewed effort led by WHO to preventing cervical cancer in the journey for the elimination. So main landmark in this journey is that in May 2018, we had the WHO call to action to eliminate cervical cancer, what was supported by many countries. And we had a global effort to develop a global strategy for the elimination, which was launched in November 2020. And also we had a continued effort to update recommendation for screen and treatment, which was launched last year in July. And I had the honor to participate in the expert group to update this recommendation, what we will talk in a little bit more later. Thank you. Next, please. So the global strategy for cervical cancer prevention set up a vision of a world without cervical cancer, and the goal of have below 4 cases of cervical cancer per 100,000 women. And to achieve this goal, we also have a target by 2030, which is related to 90% of the girls full vaccinated with HPV vaccine by 15 years, 70% of women screened with a high performance test at 35 and 45, and 90% of women screened positive receive treatment for precancer lesion or even invasive cancer. In doing that, we will have a 30% of the reduction in mortality by 2030, what we hope to achieve. Next, please. So to achieve these targets, this goal and target, it is important to assess where we are in terms of incidence. So these graphics show the incidence by region and countries. And we can see that we have some countries, few countries that already achieve the goal and target. But we have other countries that is very far from this goal and target. So when we work with countries, it is really important to identify where countries are in this scenario. Next, please. And it's also important to assess the coverage of this main intervention, vaccination, screen, and treatment. And this graph shows the situation of the several low and middle-income countries. And we have some countries that, in terms of screen, they are above the target, more than 70% of the coverage of screen, but many countries are below this target. Next, please. So in 2020, we had an assessment that showed the situation of main intervention around the world. So for HPV vaccination, in 2020, we had 85 countries with HPV vaccine in immunization programs, but most of them are below the target of 90%. And in terms of screen and treatment, most of the countries, especially low and middle-income countries, were below 70%. And also they had issue with quality of the screen. And also they were below the 90% of the treatment. And we also have a large gap in terms of access to cancer treatment and palliative care in countries. Next, please. So the new recommendation from WHO to screen and treatment launched in July 2021. In this document, we can have we can access this document through the link in this presentation. We had a total of 23 recommendations and 7 good practice statements. Some of these statements are identical for the general population and the women living with HIV, but most of them are different for the 2 different groups. Next. And I'd like to highlight that the recommendation is to move from a screen with a more complex or low sensitive method to a screen with a high performance alternative. So it's moving from screen with cytology and VIA to a screen with mainly HPV testing. But it is important to note that the recommendation is that for countries that have a program screen with VIA and cytology, should continue the program until they have the capacity to introduce and scale up HPV testing in country. Next. So some highlight about the new recommendation in terms of the target population and frequency of screen. So for the target population for HIV negative women, we should prioritize women aged 30 to 49 years for screen. And for women living with HIV, we should prioritize women aged 25 to 49 years. You remember that the previous recommendation was to start regardless of age, but the evidence has been showing that the best use of resources is to focus on women between 25 and 49 years. But if we have resources available, we can also prioritize women beyond 50, especially those that never had been screened. In terms of frequency, the recommendation is for HIV negative women, we should rescreen every 5 or even 10 years. And for women living with HIV, rescreening every 3 or 5 years, depending on the existing resource. Next. So here I'd like to highlight some remarks on effective components for CCAP program. So it is important to that the priority should be given to maximize screen coverage and treatment rather than the frequency of screen. And testing must be linked to treatment. Testing without treatment is a waste of a resource. Also, it is important to highlight equity. We should make all effort to achieve all women in the target age. especially those that are most vulnerable and hardest to reach. And also the importance of integration. So cervical cancer screening and treatment service must be integrated in all the reproductive health services, including HIV services. And it is important to establish a service delivery system. Next, please. So in GPIGO, we envision a world where an integrated and coordinated response improves downstage of cancer and end preventable death for women's cancer. Next. So here we have a list of some countries where GPIGO have been supporting cervical cancer prevention in the past and currently. And we have mainly invested in advocacy and resource mobilization, strengthening policy and guideline, health education, awareness and demand creation, increase access to vaccination, screening and treatment, and also building the capacity to ensure good monitoring and evaluation and the resources system. Next. So here we can see the example of some countries moving from screening with VIA and treatment with cryotherapy to invest in the integration of the cervical cancer prevention into reproductive health services, and also invest to introduce HPV testing and thermal ablation. Next. And here I'd like to highlight the importance of investing in the introduction of innovation. We have a lot of research around cervical cancer prevention, and it's important to support in countries to introduce these innovations in the area of advocacy, products, new products, policy, process, and also technology. I think we are in a very good moment for cervical cancer prevention with a lot of new technology, and we really need to support in countries to use these new technologies. Next. So some challenges in this process that we have been identified is that countries are prioritizing COVID-19 response, as we all know, and we have limited funds and resources for cervical cancer prevention. We have concern about capacity to ensure HPV testing in countries, and the challenge to ensure quality training, mentorship, and monitoring and evaluation with the context of the COVID-19 pandemic. But we also have some success factors that I'd like to highlight. The government COVID commitment and ownership, we have increased the interest from countries' government. Also enabling environment, coordination and partnership, leverage existing capacity. We should be flexible and creative and embrace innovative solutions and recognize and celebrate the effort. Next, please. So I'd like to end this presentation, highlight the client perspective. We need to listen to the client. So here we have some phases of cancer survival, and I'd like to end this presentation, share one quote from this guy that talking one Stop Cervical Cancer in Africa conference, and he said, cancer is not a journey for one person. Cancer is a journey for a family, friends, for a society, for a country, for the world. So we must do all of our efforts to really advance cervical cancer and eliminate this disease. Thank you very much. So maybe I should call my colleague Cornelia to share her presentation.
Hi, everyone. Thank you, Veronica. My name is Cornelia Mbifon. I am the technical advisor for cervical cancer prevention in Namibia. Before we proceed to the next slide, I would like to say 1 or 2 sentences about Namibia from a distance so that I stimulate your desire to visit Namibia. It's one of the most beautiful countries in Africa, and it is in SADC. Namibia is a young country. It got its independence in 1991. It has a population of 2.3 million people, and it harbors 2 deserts. So the terrain is very rough, and it has this alias, the land of the brace. Next slide. So here is Windhoek, the capital of Namibia, and that is the Namibia Independence Museum. So we will be discussing the goals and objectives of cervical cancer prevention in Namibia under JAPIGO. We will look at the current interventions and successes, mention challenges, consider lessons learned, and opportunities going forward. Next slide, please. So through HW21, JAPIGO in Namibia has one major goal: to provide high-quality cervical cancer prevention services to mainly women living with HIV/AIDS, but we do not exclude HIV-negative women who come up for screening. And this we do to achieve 2 major objectives: provide national level support to PEPFAR and the Ministry of Health and Social Services, or MOS as it is called here, to advance cervical cancer prevention in country. We also build health system capacity, including provider capacity to actually implement CCAP services in 4 regions. Next slide. So this is the map of Namibia, although it's not the most up-to-date because there are currently 14 regions, but this is where we work. The bright pink color is Kunene region. We also work in Erongo region, which is in blue, Hadab region in green, and Omaheke region in orange. Omaheke has the smallest population, while Erongo has the largest population amongst the 4 regions where we are working. So what is our major activity? Overall, we provide technical assistance in the area of guideline development, training on CCAP, demand creation, screening and treatment, as well as monitoring and evaluation. Next slide, please. So I will just zero down on the screening and treatment aspect. So here we provide awareness and demand creation. We give health education and pre-screening counseling, after which we provide the actual cervical cancer screening using 2 methods: the visual inspection with acetic acid and the old-time pap smear. Pap smear, we can do the conventional method using the smear or the liquid-based cytology. But I want to take this time to just remind us why we have moved from pap smear to VIA. There are so many steps between the first pap smear and the final outcome or conclusion when you are assessing the woman. So the patient must come for the screening, and then she needs to come back for results. If the results are negative the first time, you can always give a repeat screening, like we have heard from Veronica, either 5 to 10 years in HIV negative or 3 to 5 years in HIV positive. But if the initial pap smear is abnormal, the woman has to be referred for colposcopy. And sometimes where colposcopy is possible is very far. Then she goes for colposcopy and is given an appointment to come again for the actual results. So there are so many steps in pap smear, and it is associated with a lot of challenges, both for the patient and for the provider. This is where VIA really comes in, or VIA, or visual inspection with acetic acid. The advantage with VIA is that it gives you immediate result and immediate opportunity to treat for those women that are VIA positive. Next slide, please. So HW21 received funding to implement cervical cancer prevention services in August 2020. So by the time we got people on board, we actually started the screening from October 2020. So I am presenting to you data between October 2020 and September 2021. I can say boldly that we have achieved a lot, because we all know that January 2020, we all woke up with the COVID-19 pandemic. So between that time, we screened 4,616 women, and these are data irrespective of HIV status. But out of that number, 86% of the women were HIV positive. So that shows that we've taken into cognizance the very high risk in HIV positive women in terms of development of cancer. And out of that number, 3,846 were screened by VIA. That means that these women were mostly between the ages of 20 and 49, because within this age group, the transformation zone is very easily identifiable, as well as the squamous-columnar junction, because we need this to be able to do an adequate VIA. So from the 3,846 who were screened by VIA alone, 467 were VIA positive, giving us a VIA positivity rate of 12%, and this is within the benchmark. Out of 467, 439 were treated either by ablative method, but in this case, we mostly use thermal ablation, or by excision method, which means LETS, large loop excision of the transformation zone. And in total, we achieved a pre-cancer treatment rate of 94% in COVID with several lockdowns. I think this is just incredible. Next slide. So how did we achieve these numbers? Initially, we organized, we have nurses that have been hired specific for the program at the facilities that do daily screening. But at some point, as we reviewed the data, we found out that the numbers were not moving as fast as we wanted. So we had to design different demand creation strategies, including organizing outreaches. And so we planned to have 19 outreaches. We were able to do 11. And then we used to pull the files of patients on ART and take out the phone numbers that are recorded and call these women. In some cases we were successful, in other cases we were not. But in any case, once an outreach is organized, we call the women directly and they come. So during those outreaches, we give direct health education, which is targeted to the HIV positive women that have been called. We also gave radio talks and television talks just to inform the public. We spoke in English, and we also spoke in the languages that the Namibian everyday woman understands. We also developed and distributed IEC materials. And during the COVID lockdown, we did not really stop. So we encouraged the nurses to call the patients and control the flow and screen those women that turned up. Next slide, please. So the common theme in 2020 to 2021, the major challenge is COVID. But outside of COVID, we do have other challenges. Top of those challenges is actual number of healthcare workers available and the skills of those that are available. So the program per district has just one VIA nurse. And when that VIA nurse goes on leave for any reason, the VIA room is locked. by VIA, meaning the CTAP room where we screen the women. Though we have trained quite a lot of healthcare workers under the ministry, but after the training, the nurses return to their usual places of assignment. So for example, somebody can be picked from theater or pediatric ward or immunization, to go for cervical cancer training. But because this person is not hired as a program nurse, the person just goes back to continue doing what they are doing. At the end of the day, they don't really practice, and therefore they don't build the skills that are needed for them to stand in for the program nurse when that person is not around. And some of our sites, they were not having doctors that are trained in LETs. So even when women were screened, some of them could not get what we call single visit approach kind of service, whereby once you are VIA positive, you get treatment, whether it be ablative or excision. So ablative treatment was fantastic. We achieved a 98% treatment rate, but for LETs, it was slightly low because these women had to be referred to another place and to get the LETs. Next slide, please. Yeah, we faced the challenge of not having a mobile van to go to long distance sites. They have patients there, and sometimes they are not a lot. So it's very difficult to pick a nurse from such a place to send for a training and to maintain that person with equipment and other things. So such a small sites and very hard to reach facilities, they would have benefited from a mobile van, but we do not have. And then a lot of our districts are still without anybody trained in VIA. Next slide, please. So what have we learned traveling across the 4 regions that we are assigned to? Like I said, we met nurses that have never been trained in VIA, and some of them don't even do the old-time pap smear because for some reason they've forgotten or they don't have the necessary tools. But what we found mostly is that there is no HPV testing in any government facility, whether self-testing or provider, but it happens in the private sector. And of course, there is no HPV vaccination. And we know that Namibia is not qualified to benefit from Gavi, but we are working on a strategic plan and hoping that we will be able to help the government of Namibia source funding for vaccination through other means. Next slide, please. So this is my last slide. What opportunities do we have going forward? I can say that cervical cancer screening stands on 3 pillars: vaccination, screening and treatment of pre-cancer lesions, and actually treating of early cancer, if I can say that. Because if we screen, in the course of trying to screen, we can pick cancers in their very early stage that are totally treatable. So if we can do these 3 things, we are on our way to eliminating cervical cancer. We will not be able to really eliminate cervical cancer if we don't introduce HPV vaccination and do that soonest. We are hoping that we can introduce HPV testing, including self-collection by the patients themselves, and then in provider-assisted testing as well. We are right now busy completing a DEX review that will guide us to writing the National Strategic Plan for the elimination of cervical cancer. And we are working on that, hoping that we can deliver that to the government before the end of this project year. We also hope to extend training, maybe using mHealth, mobile health, to train doctors both in the private sector and other parts of the state system that have not been reached, just so that we can expand that coverage that we need so much. Like Dr. Veronica said, coverage is about getting the one woman to even do the screening for the first time in their lives, as opposed to re-screening the same person So we really need to look for ways to increase coverage. I would like to end here. Thank you so much.
Thank you so much, Dr. Ndofan. So one of the things we really hope to highlight this webinar is that synergy that's possible between our domestic and international efforts to improve women's cervical health. We've heard about some of those overlapping concerns, maligned innovations, and the connected opportunities ahead with both HRSA's Office of Women's Health and HRSA's Office of Global Health, which we hope are recognized by the domestic and international stakeholders in women's health. And both stateside and globally, improving those rates of screening has the potential to significantly improve rates of early and successful treatment. And while the specific barriers vary between the United States and internationally, a common challenge, of course, is reducing those barriers that women experience to access screenings for cervical cancer. Another challenge we can all relate to is the COVID-19 pandemic has impacted screenings for cervical cancer. It's another reason to continue encouraging the use of vaccines, both for HPV and COVID-19. All available COVID-19 vaccines are highly effective at preventing severe illness, hospitalization, and death from COVID-19. And the introduction of HPV vaccinations for adolescent girls and boys, or pre-tween, pre-adolescent, is also very critical for a long-term strategy. And with those challenges, there's hope. We heard from OWH about the new guidelines for screenings and the expanded recommendations for screening and treatment by PEPFAR programs. We also hope that this webinar encourages an ongoing conversation between domestic and international stakeholders. To that end, we want to thank all of our speakers for sharing their knowledge, all those who have contributed to the work described, which has huge impact, and all of you for attending and learning with us. I now open a brief question and answer period hosted by Ellen Hendricks from the Office of Women's Health. Thank you.
Thanks so much for those summary reflections, Alpa. And yes, we're now moving into the question and answer portion. And so our first question is for Dr. Veronica Race. How feasible is it to migrate from VIA to HPV testing for cervical cancer screening, given the capacity and cost implications, especially in low and middle income countries? Any best practices you could share for successful transition?
Yeah, thank you for this very important question. This is the question that countries has been posted to us, how they can move in from screening with VIA. And here in Chicago, we have been supporting countries to increase the screening with using the VIA, which is a really simple and low cost test. But now we are completely convinced about the importance of moving to screening with HPV test. So what we have been doing with countries is to invest in advocacy. We need to really discuss with countries and show the benefit of moving and invest in this type of test. So when we see the cost of the test per se, we can see the VIA, it's much low cost than HPV testing. But when we analyze other components of the cost, for example, for HPV testing, we can reduce the burden of women health workers, because just those women that are HPV positive need to undergo for speckle examination, for assessment, for treatment. Most of them will be HPV negative, and also the frequency of screening when you use HPV testing, it's high than the frequency of screen recommend to VIA. So when we put together all of the costs, we can see that the cost of HPV test is not so high as compared with VIA. And also when we compare the cost of screen with a high performance test with the cost of cancer treatment, we can see that it is much useful to invest in screen and treatment of pre-cancer. And in terms of the best practice and lessons learned, what we have been learning is that it is very important to invest in advocacy and have this discussion with countries, and also invest in partnership. No one can succeed alone. We really need to put together minds and effort to support the country in this movie. And finally, have good planning, rely in the regional and global experience. So we have been promoting shared experience between different countries that are already moving, talking to countries that are planning to move in. So this is really very helpful. Thank you.
Thanks so much, Dr. Rice. I love that emphasis on partnerships. Our next question is for Dr. Ndifon. And so a participant's interested to know the training methodology you adapted for the trainings of service providers, and was the screening and treat strategy followed up? If so, how many centers of cryotherapy were available?
Okay, thank you very much. We support the Ministry of Health, who actually owns the training. And so before the lockdowns became frequent and severe, we could do face-to-face training, usually starting with theory and proceeding to practical demonstrations on models before they went ahead to touch actual women. But I think in June last year, if I'm not mistaken, Namibia experienced severe or higher rates of COVID deaths, and gathering numbers were cut down to 10 and below. So at this point, we had organized a training that was going to go the usual way, but we switched to a virtual method. And in doing that, the nurses connected from their various districts. Now this is national. Remember, Japaigo is just in 4 regions, and the ministry actually leads that. And our involvement is in terms of reviewing the training materials, updating them. And once in a while, I am one of the facilitators. So we were able to have a virtual training, and people were organized in cohorts to be with the nurses at their facilities to demonstrate in small groups rather than bringing, say, 35 or 40 people to a big space. And after that training, we follow up the trainees through WhatsApp groups where we encourage people to ask questions or things that are not clear as they proceed to actually do the screening. And so they have cameras whereby they can take pictures of their supposed, say, VR positive lesions and send to us, so for quality check to confirm whether it's a true VR positive or not, and then give further advice. So I would say that that is how it worked during the most severe times when large numbers of gatherings were not allowed and movement was restricted. And so we went virtual, but this was just on one occasion. I don't know if that answers your question.
Thank you so much. And we've unfortunately reached the end of our time today. I want to give a special thanks to all of our presenters for sharing their expertise today. And thanks to our audience for joining us in honoring Cervical Health Awareness Month. A reminder that a recording of this webinar will be made available on the HRSA website in the upcoming weeks. So on behalf of the HRSA Office of Women's Health and Office of Global Health, thank you so much and stay well.